All right, so welcome everyone to the Clinician Engineer webinar series brought to you by the Clinician Engineer Hub. My name is Faisal Nawaz and I am a fourth-year medical student here in Dubai. Joining me is my co-host, Dr. Lady Katherine. And Dr. Katherine, would you like to introduce yourself?
Hello, everybody. As Faisal has introduced me, my name is Katherine. I'm a third-year medicine resident at the Cleveland Clinic, and I'm happy to have you all here. Thank you so much to our speakers and to our audience.
Great, and we also have Miss Liana joining us from Germany. Liana, would you like to introduce yourself as well?
Hello, everyone. I'm Liana Shvachiy from EIT Health Alumni Organization and Students Against COVID. Welcome, everyone.
Great. So we'll be beginning the session shortly, but just to have a few ground rules set here in terms of muting your microphones as an audience member, making sure that any questions that you may have can be typed out in our chat box for our speakers. And we will also be giving out a feedback survey at the end of both day 1 and day 2 of this webinar event. We'd really appreciate if you could fill that out as well. And lastly, make sure to enjoy this event. And it's been a pleasure having all of you with us today. Joining us as our first speaker here would be Dr. Diana Anderson. And Dr. Diana is a licensed architect and a board-certified healthcare architect with the Order of Architects of Quebec and the American College of Healthcare Architects, in addition to a licensed internist and a board-certified physician through the American Board of Internal Medicine. Dr. Diana, we will be giving you the floor now on starting off with the topic engineering and its role in hospital design. The floor is yours.
Thank you very much for the introduction. Good morning, everybody. Well, it's morning here in California. I know we're coming in from all over the world. Let me just share my slides. So what I thought I would talk about today, and I'm very grateful to be invited to this very important forum, is given my background in architecture and medicine, I thought I would touch on the topic of the hybrid clinician and this new emergence of a new field that we're starting to see. And I think now more than ever, it's time to page the engineers and architects stat to help with healthcare solutions, especially in the era of COVID, but even with respect to other healthcare issues that have come up over the years. So I thought I would tell you a little bit about what I do as a docitect. And this is my favorite quote by the architect Louis Kahn. You know, Louis Kahn gave a speech in the 1960s and said that once challenged, an architect will find new shapes and means to produce the hospital. You know, we're very good at coming up with innovative design solutions, but the architect cannot know what the doctor knows. And I'll challenge this here today with all of you and say, is this true? Can the architect know what the doctor knows and vice versa? And I think we're really seeing a new type of clinician emerging, this hybrid clinician model. And it's a very needed career model, in my opinion. The docitect model, which is a combination of doctor and architect, docitect, it's really a collaborative model that I've developed for approaching healthcare design from the medicine and architecture fields simultaneously. And I see it as a way to push this narrative forward and to help disseminate information. It might not surprise you to know that the impact of the built environment that we're in has immense impact on our health, minds, and our behavior. How a building functions and how it stands up and what it looks like are pretty central concerns to engineers and architects. But let's go deeper, and I want to pose the questions, what good does a building do? For whom and in what way? And I had completed a fellowship in bioethics last year, not as a third type of career, but really as a way to glue these two fields together. And I've begun thinking a lot more about what is our ethical responsibility as engineers, as architects, as health architects, towards designing spaces and infrastructure and cities that do no harm, but actually help heal and prevent illness. And so for most of us in North America, at least, we spend about 90% of time indoors. If we work in the hospital, which probably many of us do, that's probably upwards to 99% of the time. We don't get outdoors very much. So these spaces exert very strong and subtle influences on the way our brains function. Architecture can actually make you very sad or anxious or tired, even distracted. But it can do the opposite too. It can make you feel highly efficient and impact our cognitive abilities, our physical well-being, and our emotional health. So all of these consequences have actually been recorded scientifically. So it's becoming very evident in our field that the way spaces are designed have a measurable impact. In the past, architecture has been called many things: inhabited sculpture, frozen music. Powerful architectural statements have the power to create a sense of awe or serenity. And most of you have probably felt this walking into different religious buildings or grand monuments around the world. But you know, space design doesn't need to be grand to impact us. And I would say that everyday spaces like hospitals have the power to make us sick or help us heal. On the screen, you're seeing an example of the innovative model of psychosocial oncology or cancer care that's seen in the Maggie centers, and they are located in the UK and now in Hong Kong. Charles Jenks was an architect, and he was Maggie's husband. Maggie passed away from cancer, but he commissioned these buildings, and each one is different, with the conviction that design can facilitate better practices of care, and in doing so, health outcomes. And Charles Jenks said something very important at one point. He said, architecture may even help prolong life. A very powerful statement in terms of what buildings can do. So I think a question I think about quite often, and I wanted to pose to the group today, and I know there'll be a discussion afterwards, how do we bridge this gap between the perspectives of those who design buildings, and by the designers I mean architects and engineers and others, buildings for health, and those who inhabit them? How can we connect this gap? And I really think the answer is through the hybrid clinician role, but I'd like to dive into this topic a little bit further. So I think when we talk about the power of architecture, we often refer to the physical characteristics, right? The materiality, the form, and the shape of a building. But there's something more. There's this intangible architectural atmosphere that gets created that we have to consider. And that's really the product of the designers who are designing the buildings, but also the social actions of those who are inhabiting the space. And so I think when we consider this spatial context of health, we have to refocus this idea of the built environment as a material backdrop independent of the medical encounters, and move towards the space where an intersection of people and buildings and encounters can occur between all of them. Of course, now in the COVID era, thinking about encounters is a whole different meaning in the world of architecture. And so I think things may change. What if I told you all that I could impact how long you might stay in the hospital if you were sick and got admitted? And I could also impact how much pain medicine you might take while you were there. And for this one, I actually take off my doctor cap and I put on the architecture hat. You know, I'm not speaking as your doctor, I'm speaking as your architect. I can impact that. How is that possible? And the answer is really evidence-based design. Some of you may or may not be familiar with this field because it's relatively new, but it was modeled after evidence-based medicine. And so really began in 1984 with a landmark study by an environmental psychologist, Dr. Roger Ulrich. And Dr. Ulrich decided to look at patients who had had surgery. So they had had their gallbladders out, a cholecystectomy. Half of the patients after surgery were in a hospital room with a window, and they looked at this, a brick wall. The other half also had the same surgery, and they were also in hospital rooms, but they had a window that looked at this, a park, lots of green. Can you guess who did better? So the nature group actually had shorter hospital stays. They went home sooner, they took less pain medication, and nurses were overall more satisfied with the experience and the care that was delivered. So it impacted not only the patients, but also the staff. So now we're over 30 years out from that initial study, and we have thousands of these evidence-based design studies. So whether you might become delirious in the hospital, which is an acute state of confusion, whether you fall, sustain a medication error, or even catch an infection, all have a relationship back to this built environment question. The acoustics, the lighting, even the sink placements. There was a 2016 McGill University study that actually quantified this, because I think it's important to go beyond the anecdote and quantify what we're thinking. For every meter that a healthcare staff person had to walk to a sink, the likelihood they were going to wash their hands decreased by about 10%. And so that's quite applicable as we think about COVID and hand washing in this era of infection control. But another anecdote to highlight the importance of architects and engineers in health is this. It's another sink anecdote coming from Toronto in the early 2000s. Many patients were transplant patients who were noted to be getting quite sick, and a number of them died in these ICUs. They were getting an infection. I believe it was Pseudomonas. And this was actually tracked back to the sink design. The sinks were making people sick. And so this is a cross-sectional drawing of a sink. And instead of offsetting the faucet in this case, when turned on, hit the drain directly. And within this drain area, there's often a biofilm that carries bacteria. And given the splash that occurred, this infected people around in the room. And so this obviously wasn't going to work. So designers needed to come up with another sink design where they offset the faucet from the drain so water would not directly hit the drain with that kind of force. And now this is standard in our building design codes in certain areas. This was a solution by architects and engineers. So I think this really demonstrates the impact and the role that we have in public health. This is a simple design solution, right? But it can save many, many lives. This is another story I like to tell from my first week as a medical intern. I know there are students and residents and interns watching this. I was in the ICU in New York City, and this was an elderly patient who was in our ICU. She was in her 80s, probably some underlying dementia, but superimposed by an acute delirium. She was very confused. She had a tracheostomy, so she couldn't breathe on her own, and her heart rate was quite high. She had persistent tachycardia. We couldn't fix it. If you can see in my sketch, she was in a room without a window. And on rounds that first day, the medical team said, "Why don't we move her?" The attending physician actually listened to us and said, "I'm listening. What's the evidence for moving her to a window room?" And so we pulled Dr. Ulrich's study and a number of others and convinced the team to move her. And so overnight in her window bed room, she improved. Now, this is not to say that this is a well-designed, rigorous study. It's obviously an N of 1 and extremely anecdotal, but that wasn't really the lesson here. I think the lesson for me and my colleagues was that the medical team stopped to consider the built environment in their care plans for a patient. And so from then on, every time we considered a care plan, along with the antibiotics and the IV drips, we considered the space the person was in and what we could do to maximize their health in that place. So if we know that design can prevent illness, which I believe it can in some cases, do we have a duty as architects and engineers, similar to physicians, to inform our clients of the research out there and the potential benefits and harms? And that's a pretty loaded question. I don't know if I necessarily have an answer, but I'll ask another. Whose responsibility is it to actually conduct this evidence-based design research? Architects have taken it on, but we really don't have a subspecialty in healthcare design research, nor do we have the grant funding to even push this forward. And although architecture really has a responsibility to act in the public best interest, I think as an architect, I can often feel that I'm simply delivering a service at the client's request. And I think our role is so much greater, especially if you consider public health. The role of the hybrid clinician can break down some of these barriers. This is an example, a design solution where we don't have daylight in very deep building spaces, and a lot of the modern hospitals are quite large in terms of their floor plates. This is Mount Sinai Hospital in New York City, the emergency department, and they installed a virtual ceiling or virtual window. They're very sophisticated now to the point where we can control circadian rhythms, and you really feel like you have a taste of the outdoors, with the theory that this can decrease falls and decrease the incidence of acute confusion while people are there. Evidence-based design, like I told you in the initial study by Dr. Ulrich, that's primarily focused on patient outcomes, right? And it really began that way, thinking about patients. And I think everywhere in the media, you see headlines like putting patients first or transforming the patient experience. But I'll stop and ask another maybe controversial question. Whose voice should be prioritized when we're funding and designing hospitals and health services? In other words, who are we designing these hospitals for? The clinicians and the staff who work there for many days, many nights, and many years, the patients and their families who can be sick and experiencing some of the worst moments of their life, or the administrators who potentially run the hospital and make the capital planning and dollar decisions. I think the pendulum of healthcare design, which is what I'm trying to illustrate in this graphic, has really swung away from designing for the clinician and the staff. And there's probably many medical personnel in this webinar, and I'd love to hear your thoughts of whether this applies in your country or hospital, but we've really geared healthcare design to please the patient and consider their satisfaction. And physician and clinician and staff spaces have been forgotten. Physician lounges and offices and break rooms are now value engineered out and considered optional in our building codes. And if I advocate all the time for clinician spaces. I think that reset rooms, places where you can go to take a moment of respite, are so important in this era of burnout, especially if you consider what's happening now in the world and the pandemic. And having looked at field hospital guidelines in the last few weeks and writing a number of papers in the context of COVID, calling for areas for physicians to rest and recuperate, even in a field hospital setting, to me are extremely important, and we try to advocate for those. I do think architecture can support the caregiver's ability to heal and deliver care, but there's often this gap between our design intent and the final user experience. And so this photograph I like because it illustrates this famous urban planning example that you would learn about if you took Urban Planning 101. The professor would come in and say, if you wanted to design a university campus, go ahead and design the buildings, locate them anywhere you want, but don't pave any of the paths. Plant some grass seed, wait a year. People will make their own efficient paths that you couldn't have anticipated. And so you can see here the design intent of a paved sidewalk doesn't necessarily work because the user experience is so different. They've already made a diagonal path which is more efficient to get to the door of the building. How do we apply this to the clinical context? This is an image from the New York Presbyterian Archives. This is a medical student learning how to examine a patient a number of decades ago. You can see that he is on the right-hand side of the patient. And at least in North America and much of Europe, examining a person from the right is extremely important and taught as medical convention. Probably this is mostly convention, maybe right-handedness of most of the population, and then the fact that the right and left sides of the body are not symmetric and there are differences. Whatever the reason, in my medical school in Canada, if I were to approach from the opposite side during a practical exam, I would have no doubt lost a number of points for doing that. This is how I was trained. And then I entered this exam room for 3 years as a medical resident in New York. Can I examine my patient from the right-hand side? I cannot. This is a simple planning design decision at one point in time, but impacted me for years after that. And I found I couldn't deliver my physical exam the way I had been taught, and I felt less efficient in my care delivery. And so that's really an example, I think, of that design intent user experience gap. We've been rethinking the clinic room space to better align with the healthcare models that are now changing and becoming more prevalent. So in my current area of clinical studies in geriatric medicine, it's very important to incorporate families and caregivers. They are not just visitors, they are extremely integral to the care of that person. And we're moving beyond this hierarchy of the physician behind the desk telling the patient what they think needs to be done. It's really now much more of a shared decision-making model. And so this idea of a round table, having everyone equal, incorporating family, and we as the clinicians delivering information, risks and benefit analysis, and then having the decision made all together has really become the norm in medicine, but I don't know that our environments reflect that. And so how do we unite where medicine is going and where healthcare design is going? I think that's extremely important and can only come through this hybrid role. And so what about architecture encouraging collisions or remedying social isolation? I definitely think it can, but I think medicine needs to catch up to other organizations that have recognized the importance of promoting this type of interdisciplinary collaboration. Buildings can for sure keep us warm and ensure our privacy, but they also connect us at a spatial and temporal level as well. And this is the Salk Institute in La Jolla, California. It's a very beautiful space, a laboratory, building, and campus. And architects now focus on this type of space design to foster these face-to-face interactions. building on this parallel strategy in science, where in the Salk Institute, it isn't really the individual lab that is so impressive. It is the fact that the architect brought scientists outside the lab to speak together and to think together and to discover. So most of the scientific breakthroughs aren't happening siloed in a lab, but in these social spaces. Again, during and after COVID, I think we'll be challenged as architects and engineers to consider ways of designing for these types of interactions to keep fostering the breakthroughs, but without perhaps this physical proximity. And so that's a very great design challenge. And so I think increasingly professionals in healthcare and in design are seeking this shared knowledge and expertise. This has become a trend. And I like the concept of an anastomosis. If there's any surgeons listening, they'll know that word, so will all the clinicians. But this idea of connecting two structures that are normally divergent. So in medicine, this can mean blood vessels or tubular structures like loops of intestine. And this connection of separate system parts then forms a network, like a river and its branches. And so I think often that the healthcare design field is changing. Medicine is increasingly recognizing the value of social sciences and humanities in the way they shape their future clinicians. But on the opposite side, architecture is progressively adopting a model of evidence, empirical data, and scientific methodology within this specialty of hospital design. And so we're seeing this career convergence. I think the clinical practice of healthcare and the fields of architecture and engineering have traditionally occupied very different worlds in terms of professional, social, and cultural aspects. And there's been not many opportunities or very few for cross-disciplinary collaboration in those fields. But emerging professionals are asking to move beyond infrequent intersections. They want a convergence of career models from what I've seen, which would really be a true anastomosis of these fields. And so medicine is gaining interest in design and design thinking. This was 2 years ago, the American College of Physicians Hospitalist magazine. They did a cover story, Clinicians Dive into Hospital Design. So many emerging professionals have contacted me over the years having an interest in combining the fields that we developed this Clinicians for Design to unite like-minded individuals who are interested in infusing design into their clinical practice. This was featured in the New York Times. And then we wrote an article for The Lancet trying to talk about the convergence of architectural design and health. And all this to say is there's an interest in the medical literature now to think about other ways we can treat patients. We don't always have pharmacologic therapies, especially in my field of geriatrics, but the architecture or the space design can actually have huge preventative or treatment benefits for patients. And so I think it's time for a new version of healthcare, and to think about it that way, in which designers, architects, and engineers can facilitate these connections with clinicians, or even take on this hybrid role in order to enable access and improve health and enhance equity through built spaces. And I think we should focus less on simply aesthetics and much more on designs that can tangibly improve people's lives and the health of individuals, communities, and cities. And so that's really all I wanted to say, but I'd love to have more of a discussion. And thank you very much.
Thank you very much, Dr. Anderson, for such nice presentation. You brought up very fair points, including that there's a need of a hybrid between engineers, architects, and doctors in order to provide better care. And these not only translate into better care for patients, but also better care for family members, for everybody who's involved, and for us, the providers, who I believe that we are prone to neglect ourselves in the profession of medicine. So thank you for making it so humanizing. We have a question from the audience, which I'd like to pose to you. So Saroj is asking, how important is it for a hospital to have an in-house team of engineers and architects to implement as well as maintain such structures versus having contractual firms taking over the job of coming up with innovative hospital designs? Is it cost effective to have such teams in-house?
So that's a great question. And I have to say, I don't necessarily have a definitive answer, but I can say that people are starting to think about this. So hospitals generally and healthcare campuses have architects on site to think about any renovations, master planning, or new construction that's occurring. But we're starting to talk about now, do we need another type of role in a healthcare setting? Do we need some sort of chief officer of design or innovation or design thinking to really take that to the next level and integrate health and design together. And I think it's very different to have that kind of role than simply have architecture firms coming in who are competing to design a certain project on the campus. Cost effectiveness is an interesting question. I think especially in evidence-based design, there's a huge question of whether it's worthwhile to implement evidence-based design. But there's actually been studies looking at that. There's a famous paper called the Faisal Hospital, which is a made-up hospital. That's where it got its name. But they showed that by implementing good design up front and thinking about elements I talked about, windows, sink placement, adjacencies of different programmatic elements, that the return on investment was extremely rapid, only 1 or 2 years to recoup the money you spent up front on healthcare design. So you could say having a whole other full-time employee or FTE in a healthcare setting is expensive, but I would argue that you probably save money in the long term and have a good return on investment for having that type of role. I think it's been challenging to convince healthcare settings that this type of role is so important. And part of the reason is because it's hard to conduct these studies in evidence-based design, right? It's hard to design a randomized control trial. I'm not even sure if you could, to really answer the window question, right? Is a window really beneficial? How do you design that type of study? There's obviously ways you can control for confounding variables through statistics, but it's not easy. And as I said, architects are trying to do this on their own, and they're trying to do this on the side of their day jobs. And I think to push the research forward, we need clinicians, we need researchers, we need interested hospital administrators to help.
Exactly, because I feel that as long as it could translate into better patient outcomes down the road, which again, will have to have long periods of follow-up time, but that definitely needs to start somewhere. So we have another.
Well, just to add that big hospital design projects take, a decade to do. These big, like the Cleveland Clinic project, these are big projects that take a long time. And that the worry is that when you start designing something in year 1, by year 10, medicine has advanced, technology has advanced. So how do we keep that up? And that's a really big challenge in design. In some ways, we're tackling that is through virtual reality and mock-ups and trying to make sure that we can pre-experience the space, if you will, before it's built.
Well, thank you. We have another question from Kala. How do you see design thinking going into this?
So that's an interesting question, because I think design thinking has become such a buzzword in the media and in health design and even in medicine. And everywhere you look, there are these innovation design thinking labs that are popping up within hospitals, often run by clinicians. For me, when I think about design, because I'm trained as an architect, I tend to think about architectural design. But I recognize that design thinking is quite a different concept and applies to everything from product design all the way up to potentially building and city design, and even potentially the design of operational models within the hospital, right? Because it's one thing to give people a space, but how they use it is a whole other question. And so I think design thinking probably needs to integrate into healthcare design and integrate with architecture and medicine to work together. But I'm a little worried that this has become such a buzz term, and a lot of people are using design thinking or saying that they're design thinking, but I'm not sure that they necessarily are. And I wonder if we need stricter kind of parameters around this type of specialty.
Well, thank you. We hope. Then Shumail has another question. Is the architect's involvement then just limited to having a good view from every window?
So that's a good question. I think an architect's role is so much more than simply the windows or even the cladding of a building. And if I understand the question right, it sounds like you're interested to know exactly how much the architect is involved. And really, architects now involve the users, so we tend to meet with clinicians and users of the space, and even with patients. But I think architects are challenged with many questions, right? We not only need to design buildings, but we need to understand the processes that occur within them. And healthcare architects is a subspecialty of architecture. So just like in internal medicine, you can specialize to become a pulmonologist or a nephrologist. Under architecture, you could board certify to become a healthcare architect. And then we have the responsibility, I think, of applying the evidence and the research. So the window is one example, but there's dozens more that we would need to bring to our clients. And, you know, I've had difficulty convincing clients sometimes that the window is important, especially in the staff context. And that's why I feel the research is so important, because if we can demonstrate a benefit, just like we do with evidence-based medicine, right? We generally don't discuss treatments or pharmacologic agents with patients without having first looked at the evidence. I don't know that we should do that in design. I think, you know, what I mean to say is we should emulate that, and we should base our design decisions on empirical data. But the architect's involvement is deeply intertwined, I think, with all of the functions of the healthcare facility.
Exactly, and just very connected with your answer, Zoha has another question. How can one measure the improvement in patient outcomes in a better designed setup? Are there any substantial parameters we should look at?
These are great questions, everybody. They're very hard questions. And I think architects and doctors are grappling with these questions all the time, as are the researchers. So one measure, so I interpret this question in a couple of ways. One is measuring the improvement through a research study. And there's been a number of studies that look at a before and after type of setup where, you know, a new building is built and we study how it is before in the old building, move the patients. That also has challenges, right? Staff work patterns may change, the whole environment is different. And so I think the way we design the methodology is difficult. And I wonder if we can, as healthcare design architects, consider research settings where we would use things like virtual reality and not necessarily have to have a full building implemented to be able to study the impacts of the environment.
Yeah, and it does make a lot of sense, because the intervention takes such effort that it's not as easy as giving a pill. And just to run that kind of study that only involves giving a pill takes a lot of effort. So we can all imagine how it is to have to build a whole infrastructure and then follow up patients in order to analyze and have outcomes. So this is definitely a challenging aspect that hopefully some of the medical students and trainees are listening to us will get encouraged and will go into this field. So thank you, Dr. Anderson. We have a final question. As a physician, do you think this concept is helping the patients in specific medical departments more than in others?
So that's a good question. You know, in evidence-based design, there's literature for all different types of patients. So we have a lot of data looking at neonatal ICUs, all the way up to pediatric care and adult care, and then geriatric care. I'm a little biased as a future geriatrician, but I should say that the reason I chose geriatrics is not only because of the patient population that I get to work with, but because I think that's one area of medicine where design can actually be preventative and possibly treat. Because, you know, in geriatrics with older adults, we have no medications to really treat dementia. We have no medications that can fix a delirium. But if we prevent a delirium, that's the main goal. And we know that delirium is impacted by the space we're in, just like that patient who was in that ICU without windows. So preventing a fall, preventing delirium, even patients with dementia, designing spaces that promote memories for them and foster quality of life. So to me, I think geriatrics with an aging population is one area that I think design can have enormous benefit, not only in the hospital setting, but also in the home and the community level too.
Exactly, and these, as you mentioned, could serve also to improve patient-doctor relationship and the rapport just by, as you said, in the outpatient setting by having a more flowing design that would allow for very rapport. So thank you so much, Dr. Anderson. This has been an amazing talk.
Thank you very much, everybody. I really appreciate it.
So I'll let Faisal continue with our next speaker.
Right. Thank you again, and wonderful presentation from Dr. Anderson, and an engaging audience makes it even better for all of us here. So before we move on to our next lineup of speakers, I'd like to make sure that we give our collaborators for this event the right recognition as well. So the European Institute of Technology Health alumni have been very kind in terms of collaborating with us for the digital platform that we've hosted this event on. So thank you to them. And the Student Task Force Against COVID-19 have also helped us in social media promotion and also in fundraising for PPE donations during this time. So thank you to them, along with our other collaborators who are also PPE organizations, such as Project N95, Med Supply Drive, and Get Us PPE. So make sure to check them out and donate as much as you can during these challenging times. So thank you again, Dr. Anderson, and we can move on to our next exciting speaker. This is actually under the theme of biomedical sensors for disease detection, under which we have two speakers, Mr. George Winfield, who is from the UK. Mr. Winfield is the CEO and co-founder of Spiras, which is an award-winning technology that allows for deeper insights into respiratory function analysis using a range of technologies such as paper-based sensors. Mr. Winfield attained his Bachelor of Engineering in Product Designing and Master of Research in Medical Devices. And he's had his experience from Imperial College London. Mr. Winfield, you now have the floor for your presentation, followed by our discussion with the audience as well. So feel free to, as an audience member, feel free to ask any questions you may have in our group chat.
Great, thank you very much for, well, first off, for the introductions, Faisal, and for inviting us on to speak about Spiras. I hope everybody can see my screen. Is that okay?
Yes, we can see your screen.
Perfect, perfect. So I hope that I can give a quick brief overview of Spiras, and then we can go forward with a discussion that we planned with as prior, Faisal. But thank you, everybody. So I thought I'd touch on exactly what Spiras is before we started going for it. And now this is something where I think this will resonate with some of the ground. I just quickly added this in because Spiras originally originated from my master's thesis at Imperial College, where we were designing paper-based sensors to monitor breathing. And there was only 4 of us on this course, and it was in medical device design and entrepreneurship. And so we were tasked with this new task of developing paper sensors. And this is the technology. Now, one of the difficulties of what we were doing with this technology is that we actually implemented a conductive ink, and we printed the conductive ink on the surface of paper. And what we were doing was we were exploiting the moisture content of breath. So on a cold winter's day, you are able to see the water content of your breath and water's ability, or paper's ability, to absorb water. Now, when we placed the paper in front of an airflow of exhalation, the water droplets were absorbed by the paper, which increased the conductivity, and therefore we were able to see and generate this real-time breathing pattern using an exceptionally low-cost disposable sensing technology with high accuracy. And so this was the core concept of how Spiras started and why we took an interest into breathing, which I'll touch on later. And for any of those interested, this is the original publication from Harvard University where this came from, under George Whiteside's lab in Harvard, where Dr. Firat Gouda is the other co-founder for Spiras. And here is a very quick video of the sensor in action. So we quickly placed this into a mask to proof of concept, and we have a small electronics module behind the system that sends the information over Bluetooth at a rate of around about 50 hertz. 50 hertz. Once we then generate that signal, we then do a whole host of analytics to then look at peak-to-peak inhalation, exhalation, the breathing rate average, the depth, and the volume. And something that's got particularly interesting for Spiras is the detection of gas on breath, which has led us now to go into non-invasive kidney monitoring. And also we've made very early progress with carbon dioxide, and hopefully we aim to offer capnography with a paper-based sensor. And the team, it started out, as I previously said, you know, there's a lot of students and medics on the call. So I thought I'd add how we started to build this team, where it was myself and my co-founder, Dr. Firat Gouda from Harvard, and then Yetisen joined from the club. And we're a very small team of 5 at Spirus, and we're slowly starting to get this startup feel of what it's like to bring a respiratory medical device to market. And also how we've tried to survive as a business in the current climate, and how we try to commercialize a sensing technology, which I thought would have been a particular interest of talking about sensors, but how we actually took that from a lab research project into commercial traction to date, which I thought was a very quick overview for you, Faisal, to then take forward.
Wonderful. Thank you for giving us a starter overview of Spirus and your contributions in the field of respiratory analytics. Personally, for someone like me as a medical student, this is very interesting, because there's this overlap that's forming between engineering and the aspect of paper-based sensors, something that I would not have really thought of as someone who just go in for the patient, but not realizing that there's so much of the environment that builds around them, which comes from contributions such as Spirus. And my starting question for you, Mr. Winfield, is really to going back to the basics. What are biomedical sensors, and how do they work for someone who's very new to something like this?
Yes, I mean, going back in the context of what we have, it's essentially a sensor is like a transducer. We take one signal from one avenue, convert it into another. And so in the terms of a biomedical sensor, it's been able to specifically detect either a biological agent, a physical, or a chemical one in that nature, and being able to transmit that signal change and being able to offer analytics. So in terms of rudimentary form of what a sensor is, I think there's probably around about 3 key areas of what makes a sensor. Is that particularly one, that it's only affected by one parameter. And secondly, when you're measuring, you're not affected by any other analytes or other parameters. And the sensor doesn't affect the analytes that you're detecting. And I think that's sort of very brief overview of what we think makes a sensor is essentially that sort of context. It's being able to take one signal change. When you detect that specific analyte, you're able to convert a signal change and transmit that data to another avenue. So in the terms of the biological part of how our sensor works off water humidity. When we detect that water humidity, that then incurs ionic electrical change on the sensor surface, which then we detect over the BLE transmission to a mobile device that we have on the sensor.
Fascinating stuff, Mr. Winfield. And I think the other question that comes to my mind about a technology where you are taking the mechanical aspect of detection and then translating it to clinical care, how do you personally, in terms of your background, move into a career like this? And what would be the standard path for someone interested in a technology like this?
Yeah, well, I think there's a few avenues. I mean, really, we were coming from a very hard engineering solution. We developed this new materialistic sensor, and we hadn't really found a problem. We had this new paper sensor that measured breathing, but then it comes down to the question of, so what? You know, how does that go into build a business? And ultimately, my goal at university was to get a good grade, and I could go get a job in finance or consulting. And I never thought I'd find myself in the position that I'm in now with Spirus and spinning out our own business. And I think entrepreneurship, also echoing on the back end of this, is something that clinicians and everybody should always be focusing on. You know, you encounter problems on a daily basis. And if you can find any shortcut or new technique that offers an insight, such as what Diana was saying, on offering better architecture and how that can affect patient outcomes, then implementing those changes, you are in effect an entrepreneur. Where Spirus came from and how we generated the startup business was sepsis. Now, one of the first things I did when I was doing my thesis was that I wanted to test the sensor against the best equipment in ICU units, which is capnography for measuring breathing. Now, capnography units take a side stream CO2 sample from the patient who is ventilated on oxygen, and through that they measure the breathing rate, which is the earliest indicating deterioration. And I was sat and we were testing this paper sensor, and we were getting beautiful data which showed us the pattern was mirroring carbon dioxide, and it was beating other competitor technology, which was impedance pneumography, which takes a impedance, well, a low ampage current through the chest, and as the patient breathes, resistance falls, and that's how they derive a respiratory. But there was a problem with artifacts and motion artifacts, particularly on impedance pneumography readings. And so we were sat there astounded, and there was 3 consultants behind me, 2 technicians and a few nurses, all watching this paper sensor that costs less than a penny, and it was tracking everything. And suddenly something went off in the ICU unit, and a sepsis patient had been rushed in. And I never heard the word sepsis. You know, I was an engineer who was in the depths of the lab designing new technologies and trying to create little things that I thought were going to be great. And when we had a discussion about sepsis, I was like, well, what's the earliest indicator? Or what's the biggest problem for you? And they said, well, it's in transmissions of in-hospital patients that haven't been picked up quick enough, and have been rushed through unplanned admission routes straight into ICU, who occupy the beds. And obviously, as you guys will know much better than what I am sat here as the engineer, the outcomes when you enter the ICU is drastically different, and mortality rates increase vastly when you do reach that deterioration point. And so when we explored this further, we found that it was breathing rate was the earliest indicating deterioration, and yet in lower care wards where you can't offer capnography, breathing rate is manually counted. And so we thought having a manual count on observation ward rounds that can last up to 12 hours as directed by NICE, how can we try and track with a low cost and highly effective respiratory sensor to not only provide clinicians with confidence to act off an accurate respiratory rate when they conduct their observation rounds and conduct the early warning scores, but could we have that trend analysis? So could we see when people were breathing 4 hours before you came to see them, and have a datafied approach to offer clinicians an insight into respiratory health using this simple piece of paper that we clipped into the nose that would then start looking at inhalation, exhalation, because the thing with breathing is it's so unique. It's something not like heart rate, it's the only vital sign we have real control over. And so we thought we needed to have this almost personalized device approach to it to offer to say that someone's breathing was unique to them or it was different, and could we try and offer that approach for what we're trying to do. So that's how we tried to transition into an early startup with a business proposition into a hostile situation.
This is absolutely interesting because it started off from such basic and humble ideas, and then you transition it into something that can directly apply to a clinical setting, and especially with your mention of the ICU atmosphere and the environment around. That is something that is becoming extremely crucial now. How can we better detect changes in such an acute setting? And then that brings me to the current question, which is about our unprecedented times right now, which revolve around ICU care and respiratory analysis during COVID-19. And how do you see the potential of this technology, or how does your thinking now change with the future of Spirus for COVID-19?
Well, this is something that came obviously out of the blue. You know, our biggest problem here in the UK was Brexit, and every question around startup survival as a business was how we were going to navigate Brexit and survive. And then when something like this happened, especially with COVID-19 being a respiratory-based pandemic, it was interesting to sit back and to see how our technology could be applied. Now, one of the approaches we took at Spirus was we have a product and platform. We have this hardware product that allows us to capture data, but Spirus is essentially a software company. It feeds the data that feeds through the hardware sensor feeds to a centralized platform that we then look at the breathing analysis. So we then start tailoring breathing rate averages, trends, but we also look at external data sets. So we take weather, pollution, pollen count, and can we find external factors that may influence your breathing or from the device. So we invested quite heavily into this platform, which was a startup approach to mitigate any risk with a hard lead product, because if we invest in a product and we don't gain the market traction today, then we would struggle as a business and viability. The biggest strength that any startup has is flexibility. So we invested in the platform that allowed us to make sure we continue to develop our clinical portfolio, but alongside that, we tailor our product into consumer devices as well. So we allow businesses to take our technology and implement them into their businesses. So when COVID-19 came along, we had the back-end system and capabilities to very quickly and flexibly switch into a response. Now, we've had consultations and we've got some exciting news to come through about what we're going to do with COVID-19 very shortly. But we think it would be great to be able to offer smart PPE masks. We think that being able to offer respiratory function for key users and also users who are worried about their respiratory health, who are wearing PPE masks all the time, the technology there would allow us to monitor your respiratory function and pattern for distressed breathing. And could we then rule out if it was pollen, or if we're starting to see a decrease in pattern of this, could this be an indicator, or could this be a way of triaging and optimizing triaging parts through with COVID-19 out in the part? Because now what we do is we offer location, we can start doing all sorts of analysis and gamification with our breathing devices. So we try and take that approach and flexibility of what we're trying to do, but with particularly COVID-19, we want to try and implement the technology into disposable masks and PPE to look out for fatigue and distressed breathing signals.
Absolutely, you've summed it up very well, and the importance of having any form of innovation with PPEs is something of dire need in this global crisis. And looking at sort of the open source nature of Spirus over here, and allowing different countries and collaborations to happen with using this technology is something I'm very much interested in. And hopefully in the near future, I'd love to have more updates coming in from Spirus for any collaborations, or at least Dubai or other parts of the world who might be interested during this crisis. Mr. Winfield, I have a couple of questions coming in from our audience as well, and I'd like to address some of them here. So we have a question from Adriana, who asks, how do we adapt biosensors that were made for research to be ready for industry or practical use?
That's the age-old question, isn't it? Stopping commercialization. I think with the sensor we did, it was heavily researched. We're talking at the paper sensor stage we're at now. We have had to date around 5 years of research that have gone into sensor optimization. But there's always going to be the stages of commercialization with sensors into clinical use, and I'm sure you as medics and trials, it goes through how you do proof of concepts. So the first study that we did was, okay, let's compare against other technologies that exist on the market. And if we can show the same efficacy and also standard and sensitivity to their measurements, then we've got now a basis to go from in the industry, because we're as good as certified devices on the market. It's not to say they're not regulated, but it offers a justification then to go to a trial. When you go forward with a trial, or if you go into any regulatory body with the FDA or the CE marking process, they will ask what initial data sets you have. So building stages to that commercialization process is integral to gaining anything into the market. So it's taking the baby steps. Compare yourself against the golden standard. You can buy them off Amazon, or you can do anything to try and test how good you are against the current competition. And then you try and say, okay, then if we want to measure breathing in hospital wards, can we show that we're as good as the manual counting? And if you're as good as the manual counting, can we then say, okay, then we can now affect patient outcome, and we hope to reduce transmissions with sepsis. So these trials cost hundreds of thousands and many months to plan and gain efficacy in trials, and to be able to approve with the ethics as well. So it's been able to stage them. And this is why we've offered something in the commercial space in the consumer well-being. So while we do the tough regulatory and clinical work in the background at Spirus, in the well-being space, you can also get to market a lot sooner, such as Fitbit or any of the other devices like Garmin that take heart rate. You know, they didn't jump all the way into the FDA approval for heart rate monitoring. They took it right into where they call into consumer space and said this could be your breathing heart rate, sorry. And that's another way to generate great amount of data to justify why that technology needs to go into a hospital part. So it's been able to offer those stages to build things.
Right, and this again, I think in a way highlights the need for basic knowledge of entrepreneurship, even in medicine, because we might have some excellent ideas for moving in something from a lab-based approach to a clinical setting, but to have that guidance on how these stages work in terms of funding and trials is becoming very important to all of us. So that answers one of our questions very well. And then we have another question that has come from two of our audience members who've said it in a very similar way. So I'm going to sum it up in a way and say, Daniel and Kalab have asked, my question is very similar. Can Spirus data be transferred to remote monitoring? And what are the challenges in terms of interoperability?
In terms of the first question, in terms of remote monitoring, so what happens with the system now is we have this paper sensor that we integrate into many products, such as nasal cannulas, oxygen masks, nose clips. We then send it through to a router mobile device. So on your mobile phone, you can see your breathing pattern in real time. From there, it then enters the cloud, and that's where we do any of the heavy filtering and microprocessing of the data. And we hope to then implement machine learning trend analysis to then try to predict what your breathing rates will look like and what effect external factors are having on your breathing if we can find past the data. When we did this, we actually found that having key APIs allowed us to offer dashboarding. And so something is going live in the US now currently with a customer in the sports market. And we can see every product out there through a hardware sense because of how it links through the software chain. And this is something we proposed for the COVID-19 response, was that being able to offer respiratory analysis at home, whether it be through PPE mask, but be able to look at volumes, tidal volumes, if effectively going to remote spirometry. And being able to tailor the sports dashboarding that athletes will use to optimize their performance, because everybody monitors heart rate in sports, but nobody measures breathing. And so we built this platform, which is why I said we invested quite heavily in the platform approach rather than the hardware as to date. Through that approach, we just retail it to telemonitoring then. Being able to offer encrypted devices out there that continually send data to the cloud system allowed us then to start triaging, because we could see every device start to, if we were faulting them, we were doing a user trial, we could see exactly what was happening, whether you were using your device, whether you were compliant with your exercise regimes or medicine. And offering those APIs and data inputs is integral to any of the telemonitoring parts. So it's very, very easy for us to start to go into that now. And the second question, if you remind me of it.
Yes, so what are some of the challenges in terms of interoperability?
Well, some of the challenges, it's always going to be adoption. It is always going to be adoption. You know, you're always, as clinicians, I'm sure you're well aware that if you tell someone to do something, they'll do a complete opposite, or they will always say something completely different. And so being able to implement a system that is robust enough to handle those situations, and also is easy enough to integrate into legacy systems, is also another key situation. So being able to offer something that is easily adaptable and modular to build and scale with the business and user base. But then again, comes onto something that Diana said about, we're building technology that we hope to implement in 3 years' time, and it's being able to make sure that the problem that we see today still exists in that 3-year period as we build the system. And it's those are the main challenges, is integration and compliance.
Well, thank you again, Mr. Winfield. You've been an amazing speaker for us, and I hope this was an insightful discussion for our audience here, who've asked some very challenging but exciting questions. Is there anything else from your side, Mr. Winfield, that you'd like to add before we move on to our next speaker in line?
Exactly. Well, I've touched on basically most of the ones I wanted to go through. This is just something we did as a business where we identified parts. But if anybody did have any further questions and would like to ask them personally, please do get in touch, and I'll be more than happy to answer them or send anything through. So thank you very much for your time.
Thank you, Mr. Winfield. And now we are set to move towards our next speaker in line. But before we do so, I'd like to highlight the EIT Health alumni who have been our collaborators for this event. And this is an international organization which is built on networking for students and others interested. I'm going to attach a link in our chat box as well for people to register as a member of the EIT Health alumni. So feel free to check that out as well. Now that we've shared that part, I'd like to move forward with introducing, well, I think Dr. Katherine would like to introduce our next speaker. So the floor is yours, Dr. Katherine.
Thank you very much, Faisal, and thank you very much to Mr. Winfield for sharing such exciting and upcoming technology. Now I'd like to introduce Dr. Ruchi Gupta. She's a senior lecturer and Birmingham Healthcare Technologies Fellow at the University of Birmingham. Her research is focused on developing point-of-use and wearable optical biosensors to measure biochemical markers for timely and accurate diagnosis of diseases. Dr. Gupta attended Nanyang Technological University at Singapore for her undergraduate studies, and then she pursued her master's degree at McMaster's University in Canada, followed by her PhD at the University of Manchester. So, Dr. Gupta, now the screen is all yours.
Okay, thank you very much. I will share my screen now.
Perfect. Yes, we can see your screen now.
Okay. Okay, so I was asked to say a bit about my background, so I will start from there. So I am an electronics engineer by training, and my degree was very much focused on semiconductor device physics. So after the end of my degree, I was interested if it's possible to make logic devices, microprocessors in fluidic domain. So this brings me to my master's study where I was investigating if it's possible to make microprocessors using liquids. And one of the applications of these microfluidic processors is in biological and chemical sensing, which really led me to University of Manchester to do a PhD degree. And then I stayed on to do a postdoc and a fellowship in Manchester. And it's during this time that I started working on optical biosensors. Since then, I have been working as an academic in School of Chemistry. So I think I just want to say that in sensors and in my team, there are people from different backgrounds and different expertise, and we need that expertise to deliver these kind of sensors. So in terms of historical perspective, Professor Leland Clark is considered as the father of biosensors. And again, I would like to highlight that he was a chemist by training, but then he went on to do a PhD in physiology. And then he became a professor in the Department of Biochemistry. So Professor Clark, he was developing methods to measure metabolites and vitamins in blood because he wanted to study their role in the development of children. At the same time, he was also interested in heart-lung machine, and one of his important contributions in this heart-lung machine was to make make the components of this machine using glass, because this allowed autoclaving these components, and that was very important to prevent infection from one patient to another. So these heart-lung machines, they were very useful in open heart surgeries. And what this machine does is it takes the deoxygenated blood, oxygenates it, and then pumps it back to the body. So it takes over the role of heart and lung during the surgery. So we can see that an important requirement for this machine to work properly is to measure the level of oxygen in blood. This was initially done using visual methods. So just by looking at how red the blood is. But this is very subjective. So Professor Clark thought it would be better if we could come up with an objective measurement. And that's how an oxygen electrode, he thought of using an oxygen electrode. And he was able to do this because he was a chemist by background, so he understood how to use electrodes for this measurement. And the idea of this electrode was to reduce oxygen at platinum wire, which generated free electrons, and to measure these electrons as a current. So this is an example of his electrode that he made. It's, as you can see, a platinum wire wrapped around a glass tube. But what he observed was this electrode worked well in buffers, in clean solutions. But when he tried to use this electrode to measure oxygen in blood, the current kept decreasing. And he thought it could be because blood contains additional components like red blood cells and proteins. And these components could be blocking up the electrode and preventing oxygen from reaching the platinum wire. So he came up with a very simple solution. He used a cellophane in front of the electrode to prevent these components from reaching the platinum wire. And in this case, cellophane acted as a gas permeable membrane. So it selectively let oxygen go through, but not the other components in the blood. Then to calibrate these electrodes, he needed to make solutions with different concentrations of oxygen. And to make these solutions, he was using glucose in combination with glucose oxidase. Because glucose, in the presence of glucose oxidase, consumes oxygen. And he eventually realizes that this approach can be used for making glucose sensors. So this is how the first glucose sensor was born. So he entrapped this enzyme called glucose oxidase in a gel and placed it in front of the platinum electrode. And this allowed him to do glucose measurements. So this was maybe a sort of research stage, but then in 1980s to late 1990s, several innovations happened that led to the commercialization of these glucose biosensors. So the very first one was by Yetisen, and it looked like a pen, but it was probably too small for the end users to use. So it was adapted in the form of a credit card size reader. And now I would like to mention some of the innovations that led to the commercialization of the glucose biosensors. So the first one was the development of efficient mediators. Secondly, the sample collection was made simpler using capillary fill. And before the screen printing arrived, these electrodes were made one at a time, so they were not suitable for mass production. But with screen printing, they could be made in billions. And finally, the development of these compact instrumentation was made possible because of the microelectronics industry. So we can see that we require lots of different fields coming together and their development to deliver a commercial sensor. The other important factor for the success of glucose biosensors was market pull. And what I mean by that is diabetes is a chronic condition, and it required monitoring of glucose in blood several times a day, which was very inconvenient for the patients if they have to go to a pharmacy to measure their glucose levels so many times in a day. So even relatively modest improvements in technology were readily accepted by the patients. So with this, I would like to give you a formal definition of sensors. A sensor is defined as recognition elements in contact with a transducer. I think we talked about this in the previous discussion. So the recognition elements, they could be antibodies, or they could be aptamers, which are DNA-based recognition elements, or they could be enzymes, as used by Professor Clark in his glucose electrode. So anything that can identify an analyte, because that gives you a specific signal. And this analyte recognition element binding is converted into an easily measurable signal by a transducer. And if I say biosensor, these recognition elements are of biological origin. Okay, so in my group, we make these biosensors out of hydrogels. And some of the reasons why we make them out of hydrogels is because hydrogels are chemically very diverse. So this gives us lots of different ways of attaching these recognition elements. And we can also tailor their density of immobilization. Also, hydrogels, we can use completely solution processed methods to make these sensors, which increases their affordability, which is necessary for mass production. And finally, many of these hydrogels, they are biocompatible. And this is particularly useful for wearable sensors. Okay. In my group, we work on optical biosensors, which means that we rely on a universal property of analytes called refractive index. So I'm not sure if people are familiar with refractive index, so I try to build in a little discussion here. All materials have refractive index, which is given by this symbol N, and is related to how dense a material is to light. So it's optical density. You can think of it that way. And there is an imaginary component which is related to absorbance of the material. So as analyte binds to these recognition elements, there could be a change in the refractive index. And this change is directly proportional to the analyte concentration. Also, the binding between the analyte and the recognition element, it's a two-way process. So if your analyte concentration decreases, then the signal would regenerate. And why this is useful? This is useful because we can do real-time monitoring. So the sensor can regenerate itself. And because the change is proportional to the analyte concentration, we can do quantitative analysis. But we cannot measure refractive index change directly. We need to have some form of converting it to a measurable signal. And for this, we need to use different types of transducers. So we work on 3 different types in my group, but in the interest of time, I will only touch on grating-based sensors. So gratings, the basic principle is they consist of strips of alternating materials. And when we shine light on such a structure, it diffracts light. So we can measure the ratio of intensity in a diffracted order to the intensity of light in the 0 order. And this ratio is proportional to the refractive index contrast between the strips. So this means we can attach recognition elements in alternating strips, And as Analyte binds, the contrast between the strips changes and the diffraction efficiency changes. So this allows us to do quantitative measurements. I had some slides on how to make them, but probably I will skip those and go on to say some images of our gratings. So these are some of the images of the gratings that we have made in the hydrogels. And as I said, it's important that we make them in the entire volume of the gel because this gives us a bigger signal. And these are some of the finer pitch gratings. So, if we shine light on these gratings, as I said to you, they diffract light, so we get a pattern like this. So you can capture this pattern using a mobile phone, for example, and look at the intensity of these spots, again, using your mobile phone. In this case, we attach the pH-sensitive dye to our grating, and as we put in solutions of different pH, we monitored how the intensity of these diffracted odors are changing. So by doing so, we were able to monitor pH in real time between pH 5 and 9. So why this is important? So well, one of the things we are interested in is in objective assessment of wounds. Wounds, a lot of them, they produce exudate, which is the liquid produced by the wound. And the biochemical profile of this fluid is related to how well the wound is healing. So for example, in case of infection, the wound fluid contains lots of species, some of which are produced by the pathogen and the other are produced by the host inflammatory response. So as shown in this slide, pH is an important marker of infection. The other important markers are cytokines, which are proteins. So we have been adapting our grating to measure these proteins as well. The grating that we have developed, we are making them onto flexible substrates. The reason being, we would like to have an array of these sensors embedded in the dressings so that we can use a mobile phone then to measure a distribution of species in the entire wound bed and also at different time points. And this information could be useful for diagnostics, therapeutics, and also for understanding the wound biology. So my final slide is just to say, so far, biosensors are used for disease diagnosis at point of care and for wearables to some extent. In the future, there has been drive towards preventive healthcare and also personalized medicine. And this probably requires non-invasive or minimally invasive monitoring. So I've left a question mark because I don't know what technology that could be. But there are several challenges. So for example, the biorecognition elements are fragile. So how can we increase the shelf life of these sensors? How can we make them work over long periods of time? Biofouling is another important challenge. Many of these sensors require constant calibration, and this is not ideal if you would like to have wearable sensors. And how do we power them? Do we have integrated power sources or some kind of external power sources? Okay, so with these challenges in mind, I would like to say that we have just begun to explore the potential of wearable biosensor technologies for improving our health and well-being, and there is a lot more to come. And with that, I would like to thank everyone for listening to my presentation.
Thank you very much, Dr. Gupta, for such a comprehensive review about your work, for sharing a time perspective as well, because there are a lot of the things that you mentioned. Something as common as—
I don't know how to stop the screen share. Okay, I think it's stopped. Okay, sorry, go ahead.
It stopped. But something as common as, and something that we take for granted, like measuring the blood sugar for diabetic patients. I feel that giving a time perspective also makes us understand the importance of having these ways of finding a feedback mechanism, because I feel that's primarily what it all entails, finding a feedback, which we, in our bodies, we do have, but then when those mechanisms fail, then we have to have alternative solutions. So I like to also, I know that you've done a lot of work as far as antibiotic stewardship. And I'm just curious as far as how can you use biosensors in order to advocate for proper use of antibiotics? How will that work?
So I did not talk about this project, but yes, when we get cold, not all cold are because of bacterial infection. Many of them are because of viral infection, but there is no easy way to tell the difference between bacterial and viral infection. So there has been reports that a protein called PCT, procalcitonin, is a specific marker of bacterial infection. But it's very difficult to measure this protein because it's present in very low levels. So our work is to design a biosensor that can measure this protein in a clinic so that it helps doctors to decide whether it's a viral or a bacterial infection. And this would in turn allow making more knowledgeable decisions on the use of antibiotics.
Exactly, and it would come in very useful also for the prevention of creation of certain type of bacteria that are multi-drug resistant, and also to decrease infections like C. diff that are secondary to use of antibiotics when sometimes it's not needed. So thank you so much for sharing that piece of work with us. Now, Guillaume has a question. He is wondering, for this type of sensor, you managed to bypass that?
Sorry, I missed that question.
Oh, sorry, can you hear me?
Yes, I can hear you now.
Perfect. So the question is by Guillaume, who is asking, for this type of sensor, do you need a visual access or do you manage to bypass that?
I presume this question is related to wound sensors.
Guillaume, is the question related to wounds?
Yes, yes.
Okay.
Okay. Yes, you need visual access. So there are dressings which are transparent. So the idea is to embed these sensors in the transparent dressings so that you are able to shine light and then get a visual signal as well.
Now this is another question, or a bit unrelated to the biosensor part that you've discussed. But it seems like you also have some work in detecting and promoting quality of food and water with the use of biosensors. How do you feel that that would translate into public health measures in order to promote these issues?
Yes, I mean that's an equally important area and application of biosensors. So one of the projects that we have is also for monitoring chlorine in water, because that's an important disinfectant. So how can we continuously monitor the concentration of chlorine? Yes, so again, that's a very valid point and a very important application of these sensors.
Well, thank you very much, Dr. Gupta.
Thank you.
We appreciate your time and this very thorough explanation of the use of biosensors and all of your work. Now I will give the lead to Faisal, who's going to conclude our event.
Thank you again, Katherine, for co-hosting this part, and a pleasure listening to Dr. Gupta and our other two speakers as well. we're now moving towards the conclusion of this event here. And we'd like to thank everyone from our speakers to our audience as well. You've all been amazing. And as part of the Clinician Engineer Hub, we would love to see you tomorrow on our day 2 of this event, which is going to highlight some exciting themes on robotics, artificial intelligence, including a surprise keynote speaker who just confirmed a while ago. So we're just as excited to bring this to you tomorrow, same time again, and make sure to follow us on @ClinicEngine on Twitter as well. I hope this answers everyone's questions and insights, and we would be giving you a survey towards the end now to fill out and give us feedback about this experience. That concludes our session for today. Anything else from the audience's side or the speakers is most appreciated. And before we move towards the end, I have a small idea as well. If we can all have our cameras, or whoever is available to have their cameras on, we can have a group picture from our webinar event as well. So just for memory's sake, that would be great. Also answering a quick question, yes, there will be recordings available for the entire events on both the days.